We're going to close out here with some, as Dr. Little said, one of the highlights, I think, of this course. And these are good, bad, and ugly saves and regrets of cases that, sometimes things worked out, but they, in the interventional world, they don't always go as planned. So to kick it off, you have my boss, Dr. Neal Kleiman, presenting a case.
Well, I didn't know I was your boss. But
yeah.
in that case, so I got a little grief about my title here.
So now that after this, let's go get you grief, then you still picture your grandson.
Yeah, okay. Well, if I could show it now, I would. Okay, so this one's neither good, well, it's actually good and bad and ugly. It's unresolved. So 90-year-old teacher, retired, followed for aortic stenosis and coronary artery disease. I followed him. Both were quiescent when I first met him. About 3 years ago, he had a 32-millimeter gradient across his aortic valve and was completely asymptomatic, fairly active, and pretty happy. His CAD was moderate. He had 2 prior stents, actually. And then over the last year, he had rapid progression of his aortic valve disease, progressively increasing gradient, was asymptomatic until earlier in the year, at which time he noticed that he wasn't able to do as much as he could, got somewhere between class 2 and 3 symptoms. STS score really got him onto the low end of the intermediate range. So what would you do with the guy? Here's a hint. Huh?
Why did he get a guy?
Because he's no longer able to do what he, physically what he was able to do previously. So he's developing some dyspnea. Exercise tolerance is going down. Known coronary artery disease. Cath had these 2 lesions, proximal circ, proximal LAD. Fairly easy to take care of percutaneously with some nice results. Got about 50% better. Here's his echo. This, I spent an hour fighting with your damn machines yesterday to get these tracings. You guys have got to take IT. Is anyone here from IT? Stand up and be bold enough to show yourself. Okay.
Have you ever heard of taking a picture with your iPhone?
Yeah, but that makes lousy slides. Yeah, so anyway, a lot of struggle. This was read as a 4.5 meter jet. Good left ventricular flow. Who said what? I heard that from someone. Well, what do you think it is? 4.4?
4.0.
It was read by, I won't give away the name. He's sitting in the corner of the front row. Yeah. Anyway, so he's got AS. Good ventricular function, pretty robust jet, and symptoms that have rapid progression, new onset of symptoms, didn't go away with fixing his coronaries. So it's time to do something, this usual discussion, set him up for a TAVR. Here's the critical finding. You take a look on your left, you can see the valve annulus. If you're not familiar with what we do, we move this red cursor on your right up and down until we find the basal annular plane, which isn't really an anatomic structure. Yeah, you can change them, that's fine.
If you want to use this.
Okay. So we move this cursor up and down along this axis. We have 2 planes we do it in till we find the basal annular plane, which is where we really want to target the valve implantation. And generally, that's calcium-free. I'm going to show you this guy's CT to show you that he's anything but calcium-free. So lots of calcium along the LV outflow tract, both proximally and a little distally. Lots of calcium at any point we chose. So there is no calcium-free segment in this patient. So as you'll see, calcium's your friend and your enemy. It makes it difficult to expand your valve, but it also serves as a great anchor point because it produces friction. Once the valve gets caught in it, as you start to expand it, it stays. And that's what we did. This is a 34 millimeter valve, a good implant, post-dilated, so it's stretched out as much as it can. But take a look. He's got aortic regurgitation, which acutely is the thing we fear the most. Now, the thing that we learn about aortic regurgitation is we're really bad at estimating it. We've heard about how wonderful CT is. We've heard about how precise MR is. We've learned about all the things you can do with echo. They're all pretty bad at this. But we utilized, in following this guy, the best tool there is, which is what? Yeah. We asked the patient how he was feeling. This was as good as we could get with the valve. And the guy said, look, I'm feeling worse than I did before you implanted it. And I'm really concerned because when I take my blood pressure, my diastolic pressure is now in the 40s consistently. So this is a guy who's pretty smart. So what would you do? That's what I said. But I had to do something too. I said that. So here's what I said. I said, well, you know, look, this is a self-expanding valve. It's made of this material named nitinol that expands slowly to its original size. And with a little luck, this valve will expand over the next several months. And hopefully we'll seal these leaks. And, you know, explain these are irregular. I didn't say that. But, you know, needless to say, this is not a result we're happy with.
But I guess your options are surgery, because
Right.
STS was 3%.
Right.
It wasn't prohibitive. A valve and valve. Now, I'd be reluctant, or at least concerned, to put a balloon expandable valve in there with all that calcium. So you could just put another Evolute in just to do a little bit more radial force.
Okay. Well,
Ask you some diagnostic questions. Is the sizing right?
yes.
You have the sizing? You have
Yes.
the location, the depth?
Yeah, exactly. It does.
Yes.
It looks like it's a well placed, just not enough.
Mechanism of AI is what? One big spicular calcium somewhere?
No, he's got calcium everywhere.
You can look at the valve, so you can tell the valve is compressed. The valve is fine. You know, it's a little high. That's okay. Probably not.
So do you want to get,
Calcium coming up out of the left corner.
do you need a CT to understand more what's happening, or are you confident based on the fluoro?
Based on the fluoro that you're in good position there. And, you know, your choices are just what Neal lined out. Just, you know, do nothing, see how he does. Well, you're losing ground. Colin said the STS is 3.2. Well, who believes in STS in somebody in their 90s? I don't. Because to get an STS in your 90s, somebody had to think you were good enough to operate on. So, you know, that's such a narrow funnel that the STS in people in their 90s are meaningless. And even if we do, we're going to take 6 months of his life to get better at 93. That's a big part of what you have left. Or you could put in another valve, in which case you're probably going to put it in slightly lower no matter what valve you put in anyway, no matter what a CT shows you.
What about plugging it?
Plugging TAVR valves, particularly Evolutes, is very challenging, and not just in our experience, but in everyone I've talked to, and it just has never been very successful. It's not the mechanism, you know, like a suture or a coronat, you know, where there's like a one hole we can go after. It's usually more kind of a diffuse network.
Surgical valves have holes, TAVR valves have paths.
Yeah.
Paths are hard to find.
Well, and remember, with surgical valve, you're plugging against a solid piece of cloth. Here, you're plugging against a mesh. Okay, so we decided, here's his echo. I asked you guys which frame I should use. You said this one. So he's got a leak. He's got it clinically. He notices he feels worse. His diastolic blood pressure is lower. And, we see the jets by echo. So our decision was to implant a balloon expandable valve with the hope that we could provide more radial force as we expanded this valve outward. This is a 34 millimeter Evolute R, and it's a 29 millimeter Sapien S3. So big size, plenty of space in the annulus. But what you can see, hey guys back there, can you make this loop? Yeah, I think we do, because what you can see is that we had tried to land just at the bottom of the Evolute, and this valve slipped downwards a little bit.
So there are two on the right-hand picture, right? Two.
That's correct. So we put in a second Evolute valve. We made sure this one landed a little higher.
S3.
S3. So we've got two S3s here in sequence. We have an S6, the newest valve. And can you make this one loop also, please?
Right, yeah.
And you can see he's still got a fair amount of AR. It may be marginally improved, but not dramatically. Well, take a really careful look. And look right there. And if you look carefully, what you'll see is a little bit of contrast escaping into the right ventricle. We didn't pick this up at the time, but he's got a tiny VSD.
If it's tiny, yeah, that shouldn't be a problem.
Well, it's not a problem if it stays tiny.
The problem is if you put your catheter down the ventricle or you shoot this before, it looks like tiny needles before.
Big.
You're trying to watch it with regurgitant volume, which makes it kind of hard.
This was when it was good when we do these with right heart caths, and suddenly the PA O2 went to like 90 in the pulmonary artery.
I've seen this story before where in the aortic shot you couldn't see any SC, you put the catheter down the ventricle. And I think you were going, oh no. This is getting ugly.
Take a look. You're going to see a little bit of a whiff coming up and around.
Oh, yeah. Yep.
And we've had VSDs before. Same mechanism, balloon expansion, fairly aggressive, and a calcified left ventricular outflow tract. The ones we've had before haven't behaved like this.
That might be bigger than it looks. It's now that you've pointed it out.
It's always bigger when you shoot. If you see it shooting from the aortic column, it's got to be pretty big.
Yeah.
And you're only watching the regurgitant volume. If you put that catheter down the ventricle, it's going to light up and everybody's going, oh no. Now the good news is that
S3, or the first half of the S6, is somewhat blocking it.
Yeah, so that's good news. The other thing that's a little disconcerting or disappointing is that if you take a look right here, see this piece of metal?
Mm-hmm.
That's a prong from the original Evolute. So that tells me that the first S3 didn't fully expand the Evolute, probably because it's so constrained by the LV outflow tract calcium. So, we were disappointed. We were really disappointed. But, we watched the guy in the ICU. Next day, how does he feel? Fine. Diastolic blood pressure is really low, sort of like our spirits. He gets his echo, and it's read as mild aortic regurg. And so here we are the next day. Oh, is this the next day? Yeah. One day post-op. And you can see there's a little bit of a VSD there. So he goes home. His diastolic blood pressure is a little higher. He still doesn't feel well. And now he's starting to get peripheral edema. A little bit. Put him on some diuretics. low dose of 20 milligrams a day of Lasix. And I call him up, and he's feeling a lot better. I said, okay, well, maybe we'll just sit tight, see if this valve continues to expand, see if some tissue grows in, starts to seal the leak. But unfortunately, that isn't what's happened. And the VSD's gotten a little bit larger. Ventricles are still good. So the story ends here because this is very recent. The question is, what do we do now?
I'd get a TEE.
Okay, so I called him up several days ago. I said, how are you feeling? He's feeling good. Low dose of Lasix. So the question is he going to stay like this? Or is that VSD going to continue to expand? So Steve, you're saying no.
He's going to get worse. I would say now is a good time to do surgery. It's not a good time, but it's 10 days.
Yeah.
I mean, get a TEE. There might be a catheter option to plug it.
Yeah, I mean, this is going to be behind 2 layers of
Very
valve.
high, very, very
Well, it'd be like a,
tough. That'll be a tough one.
If he was 81, he'd go to surgery.
Yep.
yeah.
Give him a lot of negative credit for 10 years. I mean, maybe he's a bad 91, but
No, he's not a bad 90 at all.
bad 91.
So let me ask you, did you have, before everything started, did you have some invasive hemodynamics? Just like overall, what was his wedge, what was his PA pressures, kind of things,
Wedge and
so that we
PA,
could do another study and see whether a dramatic change really has happened or not? Is his PA pressure now 80 when it used to be 40, or,
Yeah, he
some
doesn't
objective data that can help
doesn't
us?
have PA hypertension by echo.
He does or does not?
Does not.
Does not. I understand, but I understand that, but it would be, you still would like to find a pathophysiology for why he feels bad. I mean, tiny VSD should not make people feel bad.
No. If they
Now,
stay
if the VSD
tiny,
gets bigger and bigger and bigger, yeah, absolutely. But
or if his RV starts to give out.
right, but he hasn't yet. It's at least in that view there, he seems to be doing okay.